on history taking in respiratory system. Respiratory disease can present to us with wide array of symptoms like that of cough, expectorant or sputum, hemoptysis, chest pain, and other symptoms which we will discuss later. So, what is the basic skill in history taking? First, you have to elaborate this chief complaint in order to go in a line of diagnosis. And after elaboration of this chief complaint, the second important point in history taking is to take negative history to rule out some other disease. Let's suppose cough is caused by respiratory pathology as well as cardiovascular pathology can also cause cough, like that of chronic heart failure usually causes cough in lying down position. So you have to take negative history that this cough is not because of heart disease, not because of chronic heart failure. If the cough is occurring in lying down position, it usually suggests heart failure cough, which occurs more in lying down position because of pulmonary edema. So the important point in negative history taking is to rule out disease of the other system or disease of the same system but other disease, the disease which is not of prime importance and disease which is taking us to the line of diagnosis. So the first point is to elaborate the chief complaint in order to go in a line of diagnosis. The second important point is to take negative history to rule out some other disease of other system or disease of the same system. Differentiate between the disease of the same system. And the third important point in elaborating the history of present illness is to look for the complication of the disease. Suppose if you are suspecting a patient to be a COPD, how does the COPD patient present to us? It usually present to us with chronic cough with expectorant. A patient will be having chronic cough with daily sputum production with expectorant. There will be no fever and the patient usually have dyspnea on exertion. The dyspnea on exertion, when the person do exertion, there is usually breathlessness. So this suggests us COPD. But sometimes there is exacerbation of COPD, that is known as acute exacerbation of COPD or AECOPD. So how we will know that patient of COPD is having acute exacerbation of COPD? There must be an increased production of sputum. Normally the COPD patient have production of sputum, but it is usually a particular amount or a fixed amount per day. But within a period of 2 or 3 days, if the person is having increased production of sputum along with fever, it suggests superimposed infection in a patient of COPD. So the disease of the complication or the complication which is occurring in the disease should be ruled out by taking history of complication of the disease. So the basic 3 rules in history taking is first you have to elaborate the chief complaint in order to go in a line of diagnosis. The second important point is to take negative history to rule out disease of the other system or disease of the same system, that is your differentials. What are your differentials for cough? We know cough is caused by many pathologies. Starting from the upper respiratory tract, we all know that upper respiratory tract, because of viral infection or bacterial infection, when it subsides, it usually causes cough for a particular duration of time, that is known as post-nasal drip cough or post-viral cough or post-upper respiratory tract cough. It is usually a self-limiting condition which causes cough. And cough is also caused by disease called bronchogenic carcinoma. So a very dangerous disease like bronchogenic carcinoma can also cause cough in a very self-limiting condition like that of post-viral cough is also present. So it is very important for us to take a proper history to differentiate and to identify what is the cause of this cough. So let us discuss each chief complaint in a detail. So what is cough? Cough is a protective mechanism protective reflex mechanism to clear the airway from foreign body and secretion. So what is cough? It is usually a protective mechanism to clear our airways from foreign body or secretion present within the airways. It is usually an inspiration. It is usually an inspiration followed by forceful expiration. It is usually an inspiratory effort followed by a forceful expiratory effort against the closed glottis, closed vocal cord. So after inspiration, the vocal cord is closed and there is sudden expiration and forceful opening of this vocal cord which produces a sound that is known as cough. So what is important in taking history of cough is the duration of the cough. Cough can be either of acute duration. When we call the cough an acute duration, if it is less than 3 weeks. If the cough is occurring for less than 3 weeks, or if the patient has presented to us for duration of cough that is less than 3 weeks, we call this cough as an acute cough. So what are the causes of acute cough? As I told you that post-viral infection also causes cough and it usually subsides by 2 to 3 weeks. So post-viral cough can present to us with acute cough, bronchitis. That is the acute bronchitis. Acute bronchitis can present to us with acute cough. So what are the other features of acute bronchitis? We will get the patient will have cough with expectorant. The patient will have cough with expectorant and sometimes or occasionally there may be streaks of blood present in the sputum. Streaks of not massive hemoptysis or not a large amount of hemoptysis but just streaks of blood attached with the sputum may be present in patient of acute bronchitis and usually the duration of the cough is less than 3 weeks. And on examination, you will find that the patient may sometimes have wheeze. The patient may sometimes have wheeze. Wheeze is also a feature of acute bronchitis. So when we think of wheeze, we think of asthma. When we think of wheeze, we think of chronic obstructive pulmonary disease. But remember, acute bronchitis can also sometimes present to us with wheeze. Pneumonia, pneumonia, pneumonia can also present to us with acute duration of cough that is less than 3 weeks. Other acute causes of cough may be asthma, acute attack of asthma. Patient might not have asthma throughout the year, but patient might present to us with an acute attack of asthma, especially in winter season. So asthma can also cause acute cough. If the duration of the cough is between 3 weeks to 8 weeks, it is known as subacute cough. If the duration is in between 3 weeks to 8 weeks, it is called subacute cough. And as we know, tuberculosis usually present to us with cough in between 3 to 8 week duration. Pneumonia can sometimes, if the patient does not present to us within 3 weeks, didn't took any treatment, then the cough of pneumonia can persist after or beyond 3 weeks, and pneumonia can also present to us with cough in the form of subacute cough. Post-viral cough can also extend up beyond 3 weeks. It usually takes 2 to 3 weeks to subside. So beyond 3 weeks, post-viral cough can also present to us in the form of subacute cough. If the duration is more than 8 weeks, if the duration of the cough is more than 8 weeks, it is usually a chronic cough. It is usually a chronic cough. Tuberculosis. The patient of tuberculosis, if he or she didn't took any treatment, the cough may persist for more than 8 week duration. If the person is having an interstitial lung disease, if the person is having an interstitial lung disease, it usually present to us with chronic cough. And what are the other features of interstitial lung disease? The patient of interstitial lung disease usually will have dry cough and have dyspnea on exertion. That is the breathlessness on activity. So the patient of ILD usually have dry cough and dyspnea on exertion. And on examination, a very characteristic Velcro crack is found. Velcro crack. What is Velcro crack? It is fine inspiratory or fine early inspiratory capitations. We will see it in detail in examination section, but if you remember it here, it is well and good. That is the fine early inspiratory crack, also known as Velcro crack, is a characteristic of interstitial lung disease. So, by knowing the duration of the cough, we can categorize the cough into three parts. That is the acute cough, which is having less than 3 week duration. It occurred because of acute process like that of acute bronchitis, post-nasal drip, acute attack of an asthma. If the cough duration is in between 3 to 8 weeks, it usually suggests tuberculosis pneumonia. If it is chronic cough, it usually occurs more than 8 weeks, and usually it is because of tuberculosis or interstitial lung disease. These are all the respiratory causes of cough. Sometimes the cardiovascular system also produces cough, especially the congestive heart failure. The cough of congestive heart failure may be chronic, and it usually occurs in lying down position when the venous pressure increases and when the left ventricle load is increased because of increase in venous return, causing pulmonary edema and causing cough in lying down position. So, patient of congestive heart failure can also present to us with cough which occur more at night time in lying down position. The patient of GERD, gastroesophageal reflux disorder, the patient of GERD, gastroesophageal reflux disorder, can also produce cough because of reflux of acid irritating the throat. It can produce cough. The patient will also have other associated symptoms if the cough is occurring because of GERD. Like that, patient may have heartburn, the patient may have dyspepsia, or patient may have chest discomfort, abdominal discomfort, epigastric discomfort, or the cough will be occurring just after food intake or just before food intake because of duodenal ulcer and because of GERD. So there may be other symptoms of peptic ulcer disease and gastroesophageal reflux disorder along with cough. This will suggest us to the diagnosis of cough occurring because of gastroesophageal reflux disorder. And simple treatment with PPIs can help this patient alleviate this cough. So the duration of the cough is important in identifying the process which is occurring, that is the acute process, chronic process, or subacute process. The type of cough. Cough can be either dry cough, that is without expectorant. There is no sputum production. There is no expectorant. Cough is dry. It occurs in disease of the pleura, like that of pleural effusion or any inflammatory condition leading to pleuritis. So disease of the pleura usually produces dry cough. And I told you just a moment before that dry cough also occurs in interstitial lung disease. Patient may have productive cough. Patient may have productive cough. Productive cough usually occur in suppurative Suppurative lung infection. Suppurative lung infection like that of pneumonia. It can also occur in airway disease like that of asthma and COPD. So suppurative cough or productive cough is a feature of infection or airway disease like that of asthma and COPD because of increased secretions occurring in COPD patient, because of increased secretions in lung infection like that of pneumonia, causing suppuration, inflammatory cells reaching the alveoli and disrupting the alveoli, causing increased amount of secretions which is cleared by the lung in the form of sputum. So productive cough is a feature of suppurative lung infection or airway disease like that of asthma and COPD. The cough can be bovine in nature. Bovine cough. What is bovine cough? Normally, I told you that the phase of cough is usually the inspiration followed by a forceful expiration against the closed glottis. So the glottis should be closed to produce the sound of the cough. The sudden opening of the glottis because of forceful expiration produces the sound. If suppose there is vocal cord palsy, if suppose there is vocal cord palsy because of recurrent laryngeal nerve palsy, so the vocal cord is open, it is not closed. Suppose there is one-sided vocal cord palsy. Suppose there is left-sided vocal cord palsy. So the vocal cord is not closed one side. So there will be no sudden opening of the vocal cord during expiration because the cord is already open. So it won't produce a characteristic explosive nature, or the initial explosive nature of the cough is lost, and where the pitch of the cough throughout the process or throughout the period of the cough is constant. So this is known as bovine cough, and if it occurs in left-sided vocal cord palsy, because of recurrent laryngeal nerve palsy, it is usually occur in hilar malignancy. It usually occur in hilar malignancy. What is the hilum? The hilum of the lung contains the left recurrent laryngeal nerve, and if there is malignancy of the left hilum, it usually disrupts the left recurrent laryngeal nerve and cause left side vocal cord palsy, which leads to bovine cough. So if patient is having bovine cough, one should suspect hilar malignancy. The other important point in history taking in cough is the trigger. What is triggering the cough? What is triggering the cough? Is there any event which is triggering or which is increasing the cough, like that of cold air? If cold air is triggering the cough, it usually suggests asthma. Cold air usually aggravates asthma. If exercise, during the exercise, if cough is occurring during the exercise, it usually suggests COPD. But if cough is occurring after some times of exercise, it usually suggests asthma. Normally, exercise-induced asthma doesn't occur during the exercise because the airway is threatened during the exercise. Why the airway is threatened during the exercise? Because of increase in sympathetic tone during exercise. As we all know, during exercise, our sympathetic tone increases, and sympathetic tone causes bronchodilation. So during exercise, the patient won't have breathing difficulty or won't have problem of the asthma. But just after the exercise, the patient, when in resting period or when in recovery period, there is no sympathetic tone helping the bronchodilation. So the patient will have attack of asthma just after the exercise. So if the person is having cough or breathing difficulty just after the exercise, it suggests asthma. During the exercise, it suggests COPD. If the patient is having cough while swallowing, if the patient is having cough while swallowing, it rarely suggests tracheoesophageal fistula. When the patient tries to swallow the food, when the food is in the esophagus, sometimes the food may transmit from esophagus to trachea because of presence of tracheoesophageal fistula. So it rarely suggests tracheoesophageal fistula if the patient is having cough while swallowing. If the cough is occurring in lying down position, if the cough is occurring in lying down position more, I already told you that if the cough is occurring in lying down position, it usually suggests chronic heart failure. Sometimes the GERD patient, because of acid reflux occurring more in lying down position, GERD patient also might have cough in lying down position, along with patients of congestive heart failure having cough in lying down position. What are the associated features? We have to ask in cough, which sometimes the patient may hear the whistling sound produced from the chest and complain to you that some sound or whistling sound is coming from my chest during night time or during activity. If the patient is complaining such, it usually suggests to us the diagnosis of COPD or asthma. If the person is having heartburn, I already told you the person is having heartburn, dyspepsia, it usually suggests us the diagnosis of GERD. If the person is having altered voice, hoarseness of voice, or change in voice along with cough, it usually suggests us laryngeal pathology. It usually suggests us laryngeal pathology. Chip complaint for which the patient might present to us is sputum production. Cough may be present with either sputum or without sputum. If it is present without sputum, that is the dry cough, it mostly occurs in disease of the pleura, that is the pleural effusion, or other inflammatory condition of the pleura. Or it might be the presentation of ILD, that is the interstitial lung disease. It might be the presentation of GERD, gastroesophageal reflux disorder. All this can produce dry cough. But if it is present with sputum or expectorant, it is known as productive cough. So the second chief complaint is the sputum production or the expectorant. What is important to know in sputum production, or what history is important in sputum production, is the quantity of the sputum, the amount or the volume of the sputum which is produced per 24 hours, If the sputum production is more than 100 ml, per 24 hours, it usually suggests a large amount of sputum production, and it usually suggests as bronchiectasis. It usually suggests as bronchiectasis. If the small amount of sputum is produced in pneumonia, acute bronchitis, or emphysema, but bronchiectasis produces large amount of sputum. The quality of the sputum. The quality of the sputum is important. If the sputum is clear, also known as mucoid, it usually occurs in COPD. Or bronchiectasis. So clear sputum or mucoid sputum usually occur in COPD or bronchiectasis. But if there is superadded infection, if the COPD patient is having superadded infection because of either bacterial, viral, or fungal infection, color of the sputum may change and it becomes green. So green sputum or purulent sputum is characteristic of AE-COPD. That is the acute aggravation of chronic obstructive pulmonary disease. Yellow color sputum or mucopurulent is characteristic of asthma or mucopurulent sputum is seen in lower respiratory tract infection, that is the pneumonia. Initially, the cough of pneumonia is dry cough, but after a course of days, the cough may be productive in pneumonia. So pneumonia, the cough initially is dry, and later on when the cell reaches the site of the infection and produces secretion, the cough becomes productive. The patient may present to us with anchovy-colored sputum. The patient may present to us with anchovy-colored sputum. So this is a brown color sputum. This is a brown color sputum typically seen in amoebic liver abscess. When the liver abscess gets ruptured in the pleura or in the lung, it usually produces a brown color sputum. This sputum is not produced in the lung, but is produced in the liver abscess which got ruptured in the lung. So the patient of liver abscess, how it present to us? It will present to us with pain abdomen. Once I have seen this patient in casualty, the surgery department was seeing this patient. Patient had chest pain along with right-sided light lower chest pain, and patient was having right upper abdomen pain. Surgery was confused whether the patient is having chest pain or abdomen. So they did both chest X-ray, ultrasound. Suppose ultrasound which was done by newly joined radiology resident, so they missed that. And the patient X-ray came out to be a pleural effusion. So they gave the case to medicine. So what happened then? That the little amount of effusion which was present there, we tapped that effusion in the casualty itself, and it came out to be a brown color pulp. So, and in palpation of the abdomen, we found hepatomegaly. So it confirmed our diagnosis. The patient is having high-grade fever with tender abdomen and pain in the right upper quadrant and first in the left pleural cavity. So it confirmed our diagnosis that brown colored part in the left pleural cavity. So we repeated that ultrasound and the ultrasound came out to be a liver. So the patient might present to us with pain abdomen and anchovy colored pus or anchovy colored sputum. We must think of amoebic liver. The patient may present to us with pink frothy sputum. The patient may present to us with pink frothy sputum. Pink frothy sputum is characteristic of pulmonary edema. Pulmonary edema because of heart failure. Pulmonary edema because of heart failure. Current jelly sputum is because of Klebsiella. Current jelly sputum production is because of Klebsiella. Rusty red sputum. Rusty red or brown sputum. Rusty red or brown, just like that of blood. Sometimes you may confuse it. The rusty sputum may be confused with hemoptysis. Rusty red sputum is characteristic of pneumococcal pneumonia. So the quality and quantity of the sputum help us guide our differential diagnosis. The consistency of sputum. What is the consistency of sputum? The stickiness of sputum. If the sputum has increased or stickiness of the sputum has increased, it suggests acute exacerbation. If the stickiness has increased, it suggests as acute exacerbation of chronic obstructive pulmonary disease. If the amount or volume of the sputum has increased, it also suggests as acute exacerbation of chronic obstructive pulmonary disease. So the quality, the quantity, and the consistency of the sputum should be asked in history, and also the odor. Odor, if the sputum is of foul smelling sputum along with halitosis and bad taste to the patient suggest as anaerobic infection like that of lung abscess. Lung abscess. How does this lung abscess occur? Lung abscess normally occur by aspiration of food particle or aspiration of foreign body usually causes anaerobic lung abscess. So the quality, the quantity, the consistency, and the order of the sputum must be asked for while taking history. Three-layer sputum. What is three-layer sputum? Three-layer sputum is characteristic of bronchiectasis. It's characteristic of bronchiectasis. The outer layer is a foamy layer. The middle layer is a mucus layer, and the bottom layer is a purulent layer, or the bottom layer is a viscous purulent layer. So three-layer sputum is characteristic of bronchiectasis. So if the patient presenting to us with cough with sputum production along with dyspnea, just I am not going into the examination finding, but based on our history only, if the patient is presenting to us with dyspnea on exertion, dyspnea we'll discuss later in this module, dyspnea on exertion, cough with sputum production, long history of cough with sputum production, there is no fever, there is no weight loss, there is daily a fixed amount of sputum which is produced, patient is having dyspnea on exertion and cough, patient is a chronic smoker patient, it suggests us to the diagnosis of COPD based on our history only. If the patient is having dry cough, dyspnea on exertion, and on examination finding, we are getting a fine early inspiratory crepitations, that is the valve crepitation. It usually suggests us interstitial lung disease. If the patient is having fever with rigors, dry cough initially, later on the cough became productive, then it usually suggests us to the diagnosis of pneumonia. So history taking is important to identify the disease or identify the process which is occurring in the patient. If the patient is having cough along with heartburn, dyspepsia, and nighttime cough, we get relief with PPI, usually suggests us to the diagnosis of GERD. If the patient is having cough in lying down position along with orthopnea, dyspnea, paroxysmal nocturnal dyspnea, and edema, it usually suggests us to the diagnosis of heart failure. So, identifying and integrating things in history taking is utmost important in going in a line of diagnosis.